Hi, my name is Matt Miller and I'm Director of the University of North Carolina Facial Nerve Center and Senior Author on the manuscript recently published in Facial Plastic Surgery and Aesthetic Medicine, Midterm Effects of Selective Denervation Surgery on Facial Symmetry in Patients with Non-Flaccid Facial Paralysis, Intermediate Follow-up of Rest and Smile Symmetry. So, to understand this research, you need to have a good understanding of what non-flaccid facial paralysis, also known as post-paralytic facial paralysis, is. Non-flaccid paralysis can occur after any in-continuity nerve insult, the nerve is injured but remains intact, or after nerve repair, either primary repair or graft repair. The most common causes of non-flaccid facial paralysis include chronic Bell's palsy, chronic Ramsay-Hunt syndrome, vestibular schwannoma surgery, trauma, and nerve repair. The aberrant facial nerve regeneration hypothesis is the leading theory of why non-flaccid facial paralysis develops. This theory describes regenerating axons extending across the site of nerve injury or site of nerve repair to both appropriate and inappropriate facial muscles. The face, in essence, is miswired as that nerve regenerates. This miswiring subsequently leads to an imbalance of the facial muscles where some muscles are relatively too weak and other muscles are relatively too strong. It can also cause synkinesis to develop. And importantly, to understand is that patients who have non-flaccid facial paralysis, whether it's Bell's palsy, whether it's Ramsay-Hunt syndrome, really do suffer from the same aesthetic, functional, and psychosocial morbidities that patients with flaccid paralysis can suffer from. Since non-flaccid facial paralysis patients frequently have asymmetry that is exacerbated by expressions such as smiling, these patients often will describe not smiling, not wanting to go out in public, and feeling depressed. And so non-flaccid paralysis really is a life-changing diagnosis, life-changing disease process for a lot of patients. So how can we think about treatments for non-flaccid facial paralysis? The last decade or so has really been a renaissance of treatment options for these patients because historically, patients were told that they can do some therapy, they can try some chemodenervation using botulinum toxin, but aside from that, there were not a lot of great options. Plenty of patients were told they had no options at all and they just had to, quote unquote, live with it. It's, quote unquote, not that bad, which again, this is devastating for patients. It really is a life-changing disease process and it takes away so much of what we value, our facial expressions, our ability to communicate, our smile. And so what we've done the last decade is we have learned that you can actually rebalance the facial muscles using procedures such as selective myectomy procedures and or selective neurectomy surgery. Selective denervation, also known as selective neurectomy, also known as selective neurolysis, attempts to rebalance these facial muscles by sacrificing distal facial nerve branches which hyperinnervate smile antagonist muscles, the muscles which are pulling the corner of the mouth and the upper lip down with attempted smile, and muscles which elevate the lower lip during attempted smile. Innervations to muscles which elevate the corner of the mouth and upper lip in a pleasing smile vector is preserved, as is neural input to the depressor labii inferioris muscle, which pulls the lower lip down during smiling, allowing for that really nice dental display, that nice dental show. And prior research has demonstrated that selective denervation surgery can significantly improve smile symmetry in patients with non-flaccid facial paralysis. Now, let's talk about resting symmetry in this patient population, because while patients with non-flaccid facial paralysis often have excellent symmetry at rest when they are not expressing themselves, these patients can have significant asymmetry at rest. The asymmetry frequently includes deepening of the nasolabial fold, lateralization of the oral commissure, elevation of the upper lip, aka a snarl appearance, and lower lip elevation on the affected, on the paralyzed side. And this asymmetry again results from increased tonic activity of certain facial muscles stemming from this miswiring of the face that has occurred. And while selective denervation's effects on smile symmetry have been pretty well studied, its effects on resting symmetry have not been comprehensively assessed. And in our practice over the years, what we have found is that sometimes resting symmetry can significantly improve after selective denervation surgery, whereas other times it remains seemingly unchanged. And so our group carried out this research to formally study what happens to resting facial symmetry after selective denervation in hopes of being able to better counsel patients. And the other goal of this research was to assess how emotions conveyed by patients' faces at rest and with smile changed after denervation surgery. Facial expressions have been termed the universal language, and so as surgeons, we should aim to improve how patients can use their expressions to convey their true emotions. Their smile should demonstrate happiness. Resting faces should not convey anger or sadness. And so the second goal of this research was to use an commercially available artificial intelligence-based automated facial expression software to assess changes in emotions conveyed in faces at rest and with smile before and after selective denervation. So now let's talk a little bit about selective denervation. How do you perform the surgery? You begin by making a facelift incision on the affected side, and you perform the classic subdermal facelift dissection. You then enter the deep plane along the line extending from the mid-zygomatic arch to the angle of mandible and then posterior to the anterior border of the SCM to give you access into the facial nerve branches that are in the neck, as well as the midface. You identify and isolate distal branches of the facial nerve. Typically, you're identifying between 10 and 20 branches. And then intraoperative nerve stimulation is performed on each branch to identify their actions. While I use monopolar nerve stimulation as an excellent way to map out the nerves to identify the different distal nerve branches, I have found that high frequency 32 Hz bipolar stimulation really allows you to be specific with which muscles are innervated by a specific nerve branch, even if they are very close together. It's a very, very specific nerve stimulator. Next, after you have identified the actions listed by each nerve branch, you preserve any branch that creates a pleasing smile vector and that activates the DLI muscle. Again, because this DLI, this depressor labii inferioris muscle, is so important for lower lip symmetry and dental display with smiling. Nerve branches which elevate the lower lip pull the upper lip down and cause lateral and downward movement of the oral commissure and elicit isolated upper lip elevation are tagged for sacrifice. And this part is really where the art of selective denervation surgery comes in. You need to keep some neural input to these hypertonic muscles or patients are at risk for articulation and oral incompetent issues after surgery, especially the mentalis. This mentalis muscle, if it's weakened too much, then patients can have temporary, but sometimes prolonged, and we're talking months, difficulty with their articulation and keeping liquids in their mouth. And this nerve selection stage is also the stage of surgery where you try to soften the face at rest while improving the smile at the same time. Weakening the mentalis often will improve lower lip symmetry at rest, as well as, of course, helping that DLI muscle function more, giving you more dental display. Now, the upper lip elevation rest, the so-called snarl appearance, is very bothersome for patients too, because it makes them, in a way, look angry when they're just trying to look relaxed. They're trying to look happy at rest. And so you can dissect distally in the upper and midface branches to try and find branches that produce this isolated snarl action. If you find them, you sacrifice them. However, I always prioritize the smile in deciding which branches to preserve and which branches to sacrifice. I, of course, counsel my patients about this ahead of time. And what this means is if you're not able to find branches producing an isolated snarl, if they are all helping produce a smile, you really can't sacrifice these nerve branches in hopes of softening the snarl appearance at rest. I think that having a natural smile that shows you're happy is so important, and this is why I prioritize smile symmetry over resting symmetry when deciding which nerve branches to sacrifice. And I think we have other ways, facial therapy, massages, stretches, chemodenervation, that can help soften the face at rest a little bit, that we don't have to only rely on selective denervation surgery to do this. Once you have sacrificed the branches that you have tagged for sacrifice, for removal, I perform a platysma resection to help with the platysma hypertonicity, and then I close the face over a suction drain. So, what were the results of this research? We used validated patient-reported outcome measures and blinded clinician-graded facial paralysis scales alongside objective measurements to comprehensively study selective denervation surgery. Similar to prior research, we showed that selective denervation leads to improved patient-reported, clinician-graded, and objective SMILE metrics. Also, this research was the first to show that patients do indeed show more happiness when smiling after surgery. The perceived happiness increased by about 25%, which is great. While resting symmetry also improved after selective denervation, the improvements were somewhat more modest compared to improvements in SMILE symmetry. Specifically, the corner of mouth and upper lip symmetry at rest improved after surgery, and patients' faces appeared happier at rest. There were not significant differences after surgery in nasolabial fold depth at rest and position of Cupid's bow at rest. So, what do we make of these research findings? This study confirms selective denervation can be an excellent procedure for patients with non-flaccid facial paralysis seeking improved SMILE symmetry. I think SMILE outcomes are typically optimized in this patient population when denervation is combined with targeted facial neuromuscular retraining, both before denervation and again after denervation. I think facial therapy is critical. And in a lot of patients, I have found that myectomy procedures such as depression anguli oris, DAO, excision, and platysmectomy really do complement denervation and produce synergistic results alongside denervation surgery. With regards to resting symmetry, selective denervation does appear to improve symmetry in the corner of the mouth and the upper lip and the face at rest. However, improvements in resting symmetry are less consistent than improvements in SMILE symmetry, likely because we are prioritizing the SMILE over decreasing neural input to hypertonic muscles at rest during surgery. In a lot of cases, such as weakening the mentalis muscle during denervation, both SMILE symmetry and resting symmetry are improved. However, in some cases, hypertonicity of the SMILE muscles results in a lateralized oricommentary, lateralized philtrum, upper lip elevation, and deepened nasolabial fold at rest. In these patients, surgeons have to try and dissect distally on nerve branches to isolate the unwanted neural input, creating that snarled appearance, creating that deepened nasolabial fold, while preserving branches which elicit a pleasing smile. This is not always possible, we have found, which is why improvements in resting symmetry are less consistent than improvements in SMILE symmetry. So, what is some important future work that should be carried out? Similar to other facial plastic and reconstructive surgery research, this study is looking at intermediate term outcomes. And future work should examine long-term outcomes to ensure the benefits in resting and SMILE symmetry after selective denervation surgery persist. One of the big questions we have in selective denervation surgery is, can aberrant facial nerve regeneration recur after surgery? And looking at long-term outcomes will hopefully answer this question. Future work also can help predict preoperatively which patients will have improvements in not only SMILE symmetry, but also resting symmetry, so that, again, we can counsel patients a little bit better before this surgery. Thank you very much for tuning in, and please do feel free to reach out to me at matthew_miller@med.unc.edu for any questions about selective denervation surgery or anything else facial paralysis related. Thank you.